I will talk about exercise, physical exercise, and its potential as an antidepressant treatment. I specialize in an area called exercise psychology, which many people don't know exists, but it exists. It is the psychology of exercise focuses on the effects of exercise on mental health, and also on what kind of psychological interventions can be applied to promote exercise or make people exercise and stick to the exercise program. So the use, and I think I'm going to show some similar studies or similar statistics that have been shown before. The use of antidepressants in Italy is not one of the highest in Europe, certainly, but as you can see, there has been a significant increase, which is also the case for most of the European countries. But in Italy, the percentage is still below the average for the European Union. Professor Carpiniello showed this study before, and I want to show and try and explain it again. So this was a highly controversial meta-analysis that was published in 2008, and it basically showed that the difference between antidepressants and placebo becomes clinically meaningful only for those individuals who present with severe levels of depression. So, in part because of this meta-analysis, and the meta-analysis wasn't exactly the first time that this finding had been published in the literature, but in part in reaction to this meta-analysis, there has been more of an increase around the world in a shift from the typical model of treating depression, which is almost entirely or overwhelmingly with antidepressants, to a more stepped approach where you evaluate the severity of depression and then you provide low intensity treatments in cases of subthreshold or mild or moderate depression. You provide cognitive behavioral therapy for cases of mild, moderate, and in some cases as adjunct therapy to severe, and you restrict the use of antidepressants for some cases of moderate and all cases of severe depression. So this is, as you can imagine, this is a very different approach to what was going on previously. So stepped care approaches to the treatment of depression are now being introduced in several countries. Perhaps the best known example is the United Kingdom, where the new treatment guidelines for major depression that were published in 2010 in England and in Scotland now have incorporated this type of stepped care approach to depression. So for cases of subthreshold or mild or moderate depression, what the physicians in the United Kingdom are now supposed to recommend is options, and these options do not include pharmacotherapy. They include low-intensity treatments. So one is individual guided self-help based on CBT. So this is books for that the patients can take home, and they explain how they can apply principles of cognitive behavioral therapy to themselves, computerized CBT, or a structured group physical activity program, and they explain what kind of physical activity program that might be. It's pretty much similar to what you would expect, delivered in groups with support from a competent practitioner, exercise professional, consists typically of 3 sessions per week of moderate duration, 45 minutes to an hour, for 10 to 14 weeks. If you're curious, in the United States, the American Psychiatric Association has also issued guidelines in 2010, and this is the formal treatment algorithm, and it does not directly include any reference to exercise. There is a little bit of a stepped approach in the sense that there is a distinction between mild to moderate depression, severe without psychotic features, and severe with psychotic features. But there is no exercise as a treatment option. The treatment options are pharmacotherapy, depression-focused psychotherapy, combination, or electroconvulsive therapy. However, they do mention that if a patient with mild depression wishes to try exercise alone for several weeks, there is little to argue against it. So at least they recognize this is not a very enthusiastic endorsement of exercise, but it recognizes the fact that, as was mentioned before, an increasing number of patients are asking for non-pharmacological options. So more and more patients hear in the news that exercise could be an option for antidepressant treatment, and they ask their physicians, can I try it? Should I try it? And the American Psychiatric Association says as long as the patient is healthy, physically healthy, and as long as the depression level is mild, there is little to argue against it. Okay, so what is the evidence behind it? Many people are surprised by how many studies actually are out there on the effects of exercise on depression. There are approximately 40 randomized control trials now completed, and the number is increasing. So this is just one example, and it's an interesting example because it's one of the very few that had a head-to-head comparison between exercise and an antidepressant drug. So this was a 16-week randomized control trial. The medication here is sertraline, exercise 3 times a week at 70%, or a combination, a full regimen of sertraline or and a full regimen of exercise. On the left, you see the changes measured with a Hamilton rating scale for depression, and on the right is the Beck Depression Inventory. And as you can see in the graph, there are decreases in each of the 3 arms of the trial with no statistically significant difference between those 3 treatments. In other words, the reduction with exercise was just as large as the reduction with sertraline, just as large as the combination. Perhaps even more interesting is the follow-up, which was at 6 months, and you see the recovery rate, and with the recovery rate, the results are clearly more positive for those in the exercise group initially compared to the results with the patients on sertraline or the patients on the combination treatment. Now, one thing that they pointed out in this paper was that perhaps there is a selection bias in the sense that the people who signed up for this particular trial were presumably positive to the idea that exercise could be used as a treatment for depression, therefore perhaps had a positive attitude towards exercise. Now, what is interesting then to examine is the response of the medical community to this evidence. So these are data collected from a foundation in the United Kingdom, the Mental Health Foundation. And as you can see, exercise, according to what the physicians themselves say, exercise is recommended only 4% of the times as the first option for individuals with mild and moderate depression, whereas antidepressants are recommended 45% of the time for individuals with mild and moderate depression. When you ask the patients themselves, as you might expect, the numbers are slightly different. So antidepressants are prescribed 46-1 over exercise. But when you ask the patients themselves, interestingly enough, if you had a choice between antidepressants and exercise, only 4% say that they would prefer the antidepressants to exercise. So another study that was mentioned before that was conducted in Australia. This is a survey. It's an online survey, so this is not an experiment. based on approximately 2,600, 2,700 respondents. They were asked to rate each of 30 different formal and informal treatments for depression. All the participants on the survey had been diagnosed with major depression. And this is how they rated these 30 different treatments. So this is perceived effectiveness. And in perceived effectiveness, exercise yielded the same perceived benefit as the highest rated antidepressant, which was venlafaxine. But then they also asked about the burden, meaning the side effects, the perceived side effects and the impact of the side effects on their quality of life. And when they took the benefit to burden ratio, as you might expect, exercise had the highest rating. So what is the problem? The problem is that we have a very inactive population, right? The problem is to get people physically active. So this is from the Eurobarometer a few years ago. And as you can see, at least based on self-report, Italians are not among the most active Europeans. So this particular graph shows the percentage of people who said never to these two questions. How often do you exercise or play sport? Never. How often do you engage in physical activity such as cycling from one place to another, dancing, gardening, etc.? Never. So the people who said never to both, okay? And as you can see, approximately half of Italians say never to both of those questions. The problem with self-report data is that they always make things seem better than what they actually are. So in the US, in the United States, also about half of the people say that they never do anything physically active. But in the United States, the government gave enough money so that they did the first ever national study where physical activity was measured objectively with a device called accelerometers that people were wearing for an entire week. So this device can actually distinguish between low levels of movement intensity, medium levels, and high levels. And then you can calculate at the end of the week whether they have done the recommended amount of physical activity or not. So what percentage of Americans participate in physical activity at least at a moderate intensity for at least 30 minutes a day on at least 5 days per week? If you ask them, about half say they do. If you measure it, it's 3.2%. So when you look at the previous graph about Italians, you have to remember that that number is probably an exaggeration. So in exercise science, there has been a significant transition in the last 20 years or so of what we recommend to the public as a way of using exercise to improve health. The old model, which is what we were recommending until about the mid-1990s, looked like this, where you would actually have to become like an athlete in training. The new model, since about the mid-1990s, looks more like this. So we now recommend more of an increase in physical activity, incorporating more movement in everyday life, spending more calories, increasing the caloric expenditure through physical activity throughout the day. So the current recommendation, and this is from the World Health Organization, is for 150 minutes of moderate intensity aerobic physical activity during the week, or if you choose to do something more intense, more vigorous, 75 minutes throughout the week, or a combination of the two. Now, I'm switching to a more psychology or exercise psychology mode to tell you what exercise psychology is doing in trying to understand and promote physical activity. The old model that we were using, and some continue to use, is known as the rational educational model. And that's the standard model that is used in public health. In other words, if you want to change the behavior of people, what you do is you educate them. Because we presume that people are rational beings, right? They make logical inferences. If you tell them that this is good for you, the presumption is that the patient would then get up and go and do it. And to some extent, that approach has produced some results. So, as you know, information, for example, about tobacco is part of the reason why tobacco rates have declined in most of the industrialized world. I'm not saying that this is the only reason, but it's part of a big picture of a public health intervention that has produced positive results. So the same kind of approach has been tried with exercise, trying to tell people, well, if you exercise, you reduce your risk of dying from chronic disease by 50%. You reduce your risk of diabetes by 2/3. And unfortunately, it doesn't seem to be working. So this is an example from the American Heart Association. Again, focusing on information. The lack of physical activity doubles the risk of heart disease and stroke. So we are now questioning this approach because we haven't seen any changes. We haven't seen the kind of changes that we've seen with tobacco, for example. So there is an area of science that deals with human decision making. And it's not in psychology, it's in economics. It's called behavioral economics. It has nothing to do with money. It has to do with the science of humans making decisions. The literature on behavioral economics on this issue, I think, is more advanced than psychology, because it has looked at human behavior outside of some theoretical models that are too restrictive about how humans make decisions. This is Herbert Simon, and Herbert Simon is an economist who suggested the idea that humans are not as rational as we think. And it's very easy to demonstrate the limits of human rationality. And for this simple idea, the idea that human rationality is limited, he got the Nobel Prize in Economics in 1978. So now you're beginning to see some of this in the medical literature as well, using insights from behavioral economics and social psychology to help patients manage chronic diseases. And you see statements like this: patients may not always be the rational actors that we imagine. This is a very important, I think, point, and in the next 10 or 20 years, I think we will start to see more and more of this new perspective, where we do no longer assume that the person across the table from us is rational and will take advice, will take information, and then rationally act on that information. So if humans don't make decisions based on the rational analysis of information, what do they base their decisions on? So these are Amos Tversky and Daniel Kahneman, and they suggested that humans use heuristics and biases. Heuristics are simplified rules. They may not always be right, but they help human beings make decisions in difficult situations. Simplified rules of thumb. Tversky had passed away, but Kahneman, a psychologist at Princeton, won the Nobel Prize in Economics in 2002 for this idea. One of the heuristics in particular is known as the affect heuristic. And the affect heuristic is nothing more than the idea that humans do what makes them feel better and avoid what makes them feel worse. It's very, very simple. So let's look at a simple study that tried to change the message from you should do this because it's good for you to a message you should do this because it feels good. So they gave people two different messages. One was the cognitive message. For example, regular physical activity reduces the risk of developing colon and breast cancer. Regular physical activity helps build and maintain healthy bones, muscles, and joints, and so on and so forth. The affective message, on the other hand, told people regular physical activity has been shown to reduce anxiety, depression, and stress. Regular physical activity often improves the way one feels about their body or appearance. After only 20 minutes of moderate to vigorous physical activity, anxiety symptoms have been shown to decrease, and so on. Do you expect to see a difference in response to these two messages? And indeed, there was. So in two different studies, you can see this is exercise sessions that people attended per week. And with the affective messages, the increase is clearly larger. In other words, people are perhaps more willing to respond to the idea, you're going to do this and feel better now, as opposed to the idea you should do this because you will reduce your risk of something bad happening 40 years later. So now, interestingly enough, the American Heart Association is changing the message, and instead of emphasizing you should do this for your heart, you should do this for your vessels, you should do this for your metabolism, you begin to see messages like energy. You should do this because you get more a sense of energy. So I want to show you a couple of examples of how people respond to exercise, and then explain how that can be applied clinically. So this is a scale that we use during exercise, very, very simple. It's called the feeling scale. +5 means I feel very good. -5 means I feel very bad. If you manage to change the way that people say they feel during exercise by only 1 unit on this scale, which has 11 units, if you change it by 1, that translates to 38 minutes of additional moderate or vigorous physical activity 6 months later, or 41 minutes per week 12 months later. How do you do it? One issue is intensity, the intensity of exercise. A lot of the patients that you see, that we see, come to us and they have been sedentary for decades. 10 years, 20 years, 30 years. Many people haven't done anything after the university. So it turns out that intensity is quite important, because when you're that out of shape, you cannot maintain intensity very low, so people overdo it. So these are results showing the relationship between blood lactate accumulation in the muscle, which of course, as you know, responds to the intensity of exercise, and the percentage of people who report improvements in how they feel during exercise. So the higher the intensity, the worse people say they feel. This is the percentage of people who say that they feel better is reduced. And on the other axis, it's the reverse. So as intensity increases, the percentage of people who feel worse increases. Each of these dots is a study, a different study that includes, about 30 individuals. So I will tell you a little bit exercise physiology, which I know that perhaps you haven't seen before. So this is, imagine that this is intensity. This is the oxygen that people consume as they exercise, which increases as the intensity increases. And this is the carbon dioxide that they breathe out. Okay? Oxygen in, carbon dioxide out. This relationship is linear up to a certain point. For each 1 unit of oxygen going in, there is 1 unit of carbon dioxide coming out. But then there is a break point. And we call this the ventilatory threshold, or VT. And at this point, you begin to breathe out more carbon dioxide than the oxygen that you take in. And this has something to do with the amount of lactate that accumulates in the muscle. And then there's a second break point where you start to breathe out even more carbon dioxide than the oxygen you breathe in, and we call this the respiratory compensation point. So there are 2 break points: ventilatory threshold, respiratory compensation. Why are these important? If people exercise below the ventilatory threshold, most of them feel better. So this is what you would see. Each line here is at least one individual. In some cases, there are two individuals that are exactly the same. At least one individual. So most of the lines go up. This is what you would get if you did a walk where you chose your own intensity. Nobody pushed you. You just selected to go for a walk at your own pace. Most of the lines go up. Most individuals feel better. If you go higher, if you go between the ventilatory threshold and the respiratory compensation point, what you find is that some people feel better and some people feel worse. So some that are interested in more vigorous exercise would love it. But then you also have some individuals that don't like it. So something like this happens, where half of the lines go up and half of the lines go down. And needless to say, if I go even higher, above the respiratory compensation point, so I bring people close to their maximum capacity, this happens. Most of the lines go down. Almost everybody feels worse. So to summarize, this might be one individual as they respond to increasing levels of exercise intensity. This might be another individual. Here is where you have the differences, individual differences between ventilatory threshold and respiratory compensation. So you can think of exercise intensity as having three zones. In one, you have homogeneity with almost everybody feeling better. Here you also have homogeneity, but almost everybody feels worse. And then in the middle, you have a zone of variability with some individuals feeling better and some individuals feeling worse. So from a clinical standpoint, you immediately begin to see some implications. If you recommend exercise here, you're almost guaranteed that most people will derive a positive experience from it. If you recommend an exercise that's more vigorous, like a jogging, you start risking, because some will be fine, but you also have some people that will find that unpleasant. So here's an example of people coming to us, this is on women specifically, coming to us with at least a year of no exercise, but most of the women, these were middle-aged women, most of them had not been active for many years. And we had two conditions. In one condition, we told them you can select your own intensity, go as fast or slow as you want. And in the other, we took the intensity that they selected and we made them go 10% faster. So if they chose to walk at 2 miles an hour, we made them walk at 2.2. Okay? What intensity did they select? So this is the intensity. So this is percentage of oxygen uptake at the ventilatory threshold. And what the women do is that they select, this is the ventilatory threshold. They don't know this, of course, but they intuitively select intensities close to the ventilatory threshold. Why? Because if they were to go any faster, they would feel bad. So intuitively, they choose to walk at an intensity close to the ventilatory threshold. This is pretty good exercise. 84% of their maximal heart rate. That's pretty good exercise. So you don't really need to go any faster. But we made them go faster by 10%, and this is what happened. They went to 91% of their maximal heart rate. There's no need to go to 91% of your max. How did they feel? When they self-selected, and remember, these are people off the couch. They haven't done anything in a long time, right? They haven't done any physical activity in a long time. Steady and positive. But when we made them speed up by 10%, just a little bit, this is what happened. So the difference is sending somebody home feeling nice and steady, or sending somebody home remembering exercise as something that made them feel like this, worse. Another little trick is music. So we had three conditions here. One was control. So they're wearing earphones, they cannot hear anything, they cannot see anything, everything is blackened out. In this case, we had something called attentional association. We tried to make them pay more attention to their body. So they're looking at their heart rate, this is a microphone in their mask, and it goes and it gets amplified and it comes back at 80 decibels. So they're hearing their breathing at 80 decibels. Right? And in this case, they told us what music they liked, and we played their favorite music for them. And this is what happened. This is from the beginning of exercise, and then we increase the intensity until they say, I cannot go any longer, right? So this is incremental intensity. And you can see the red triangles here is the music television. And you can see that especially when exercise starts to get a little hard around the ventilatory threshold, music television helps. If you go higher, however, you can see that regardless of what you do, people are going to feel worse. So if somebody cannot maintain a low intensity because they are too heavy or they are too out of shape, music can help. So that's all I had about exercise, and I will be happy to answer questions afterwards.